Moving on to the next presentation, I am pleased to invite Dr. Sam P. Abraham, laparoscopic surgeon and infertility specialist at Abraham Advanced Infertility Research Center. He'll be speaking on the topic varicocele and infertility current concepts. Let's welcome Dr. Sam P. Abraham.
I am grateful to Jayakshan sir for giving me this opportunity. I am here to present on varicocele and infertility. Varicocele is an abnormal dilatation and tortuosity of the internal spermatic vein within the laminiform plexus of the spermatic cord. It is characterized by the bag of worm mass in the scrotum. Patient may be completely asymptomatic or patient may be having a complaint of scrotal pain, often brought on physical exertion or on prolonged standing. So, it is seen in 15% of the general population and 14% of men present with infertility. So, not all patients with varicocele have infertility. Sometimes it may be found accidentally. It can be due to incompetency of the valve, or it can be due to some pelvic or abdominal mass. It usually develops more intensely on the left side because venous return is more difficult due to the anatomical peculiarity of the internal spermatic drainage on the left side. It could be due to the nutcracker phenomenon because the left renal vein is between the superior aorta and the superior mesenteric artery. There is a compression of the left renal vein between the aorta and the superior mesenteric artery, and that accounts for the varicocele in some boys. So what are the clinical features of the varicocele? The patient may present with swelling. The patient may say of some dragging or aching pain in the groin. There may be a feeling of bag of worm appearance. Scrotum on the affected side may hang down. On lying down, the patient will say, I get the symptoms reduced. That's an important sign. You hold the varicocele between the thumb and the fingers. The patient is asked to bow. You can see that the mass gets reduced. And you will be able to feel a cuff impulse. In long-standing cases, you can see on the affected side of the testes will be softer. And sometimes you can see infertility also. So this we have to be very clear because spermatogenesis occurs in the testes within the scrotum at a temperature which is 2 to 4 degrees lower than the body temperature. That is very important for the viability of the sperm cells. That is why the God has created that way. There is intratesticular thermoregulation. So you can see that there is an increasing surface area of the testes. How this is brought? The cremasteric muscle which is around the testes and the spermatic cord and the dartos muscle beneath the scrotal skin relaxes, then makes the testes away from the abdominal wall. The cremaster muscle, the spermatic cord and the dartos muscle, that what does do? It relax and make the testes away from the abdominal wall, so it allows the maximum heat loss. And another is we can see that the scrotal skin is different from other part of the skin. We know that the scrotal skin is thin. It has got minimum subcutaneous fat. It has got scanty hair distribution and dense sweat glands. So what does it do? It has got that skin has got its own intratesticular thermoregulation mechanism. There is a counter-current mechanism there because testicular artery carries the cool oxygenated blood to the testes. Testicular vein bring warmer blood to the testes. So this counter-current mechanism controls this heat exchange mechanism. So varicocele, what does it do? It embeds this heat exchange mechanism and therefore it hinders the cooling of the arterial blood before it enters the testes. This alteration in blood flow prevents the testes from maintaining the lower temperature. As I already highlighted, the temperature maintenance is very important for proper spermatogenesis. So how does varicocele cause the changes? It causes macroscopic, microscopic and functional changes in the testes. How? It causes dilated laminiform plexus. There is a stasis and backflow of the warm blood into the internal spermatic vein. It decreases the testicular volume. There is abnormal Leydig cell function. There is a build of toxic substance in the testes from the decreased venous drainage. All these leads to diminished spermatogenesis. So varicocele definitely affects the spermatogenic process. So what does it do? it leads to lower testosterone level and leads to impaired steroidogenesis and lead to lowered Leydig cell dysfunction. Alteration in the seminiferous tubule changes, it causes seminal variable changes and lead to decrease in sperm concentration, motility and morphology of the sperm cells. So sperm from patients with varicocele possess lower ability to bind to human oocyte zona pellucida. So the sperm binding to zona pellucida gets altered. So it has got effect on spermatogenesis. So spermatogenesis is a continuous proliferative process. It leads to production of millions of sperms per day. So apoptosis is present in both physiological and pathological situation and will determine during gametogenesis the sperm concentration. Apoptosis is associated with nuclear DNA fragmentation. It occurs in spermatogonia, spermatocytes and spermatids. Heat stress, androgen deprival and accumulation of toxins in the testes all contribute to this abnormal rate. So we can very clearly understand that varicocele definitely contribute to abnormal spermatogenesis. So what does it lead to? Men with varicocele present with lower sperm motility, and this may not be accompanied by alteration in other sperm variables. So three basic causes why the sperm motility is affected. There is an increased concentration of reactive oxygen species. There could be presence of anti-sperm antibodies and there could be deficient mitochondrial antibody. All these leads to a decrease in sperm motility. So does it affect the sperm morphology? Yes, because that causes abnormal increase in fusiform and amorphous cells. There is an increase in mid-phase cytoplasmic droplets which lead to lowered sperm motility. You can see that varicocele leads to an alteration in the morphology and motility of the sperm cells. So does it affect the acrosome function? We know that when a single sperm enters to the egg, it gets sealed off. So acrosome reaction is also affected because acrosome reaction is calcium dependent, and varicocele, patients with varicocele, they have an altered calcium influx mechanism. So what does it do? Acrosome reaction is calcium dependent and few motile sperms are able to complete this process. So acrosome reaction also get altered with varicocele. So you can see that environmental incel stress, genetic predisposition, anatomic deficiency, dilatation in paminiform plexus, progressive toxic effect, impaired spermatogenesis, decreased testosterone, testicular atrophy, decreased sperm quality, all this could lead to abnormal sperm morphology, abnormal sperm functions. So how can you diagnose varicocele? We have to see that you should examine the patient in a room which is not in a cool or AC room. It should be in a room which is more than 23 degrees Celsius with the patient in the upright position. If there is an observable, palpable dilatation in the paminiform plexus before or doing Valsalva, it is confirmed. But there are cases where there may be grade 1, grade 2, grade 3. What is grade 1? Grade 1 is one where the varicocele is visible with difficulty but easily palpable during the Valsalva maneuver. Sometimes this may be also clinically important. Grade 2, they are visible, but there is venous gorging during the Valsalva maneuver. Grade 3 is one, varicocele are easily visible with gray reflex during the Valsalva maneuver. So these three grades are important. Again, I mention you should be examining the patient in a warm room, not in your typical cool room. So if you are able to see, you see dilated vessels ultrasound which are more than 3 millimeter. You can see the image demonstrating significant reflex of the vascular flow with the Valsalva maneuver, confirming it to be the varicocele. Now, when you do the color Doppler, you have to have certain features. So, if you have the reflex in the inguinal channels detected only during the Valsalva maneuver, while scrotal varicosity is not evident, that is one, grade 1. Grade 2, small posterior varicosities are there that extend to the superior pole of the testes. The diameter increase and venous reflex is present only in the supratesticular region, and that too in the Valsalva maneuver. What is grade 3? Varicocele appear even in the inferior pole of the testis, when the patient is evaluated in the standing position and no engorgement is detected, even if the patient is examined in the supine position, reflex is observed only during the Valsalva maneuver. Here you have the varicocele observed at the inferior pole of the testis when the patient is evaluated in the standing position, but you don't have it when the patient is examined in the supine position. What is grade 4? You have the vessels appearing enlarged even when the patient is examined in the supine position. What is grade 5? Venous ectasia is evident even in the prone decubitus and supine position. So that is grade 5. This is how you grade as per the Doppler criteria. So this Doppler criteria is very important. So you have got the diagnosis also. Then what is the indication for varicocele? Male factor subtlety. Should you treat in adolescents? Yes. Suppose you have to suppose a patient in adolescence comes to you with dragging pain with all these 5 diagnoses. You have to serially follow the patient with testicular volume and you have to examine his testosterone level. And if you see a testicular hypertrophy in adolescence, you have to follow that patient. And you have to look at his 7 parameters also. So, in a patient with testicular hypertrophy, if you see a decrease in his testicular volume and you see evidence of testicular hypertrophy even in adolescence, there is an indication for varicocele. And if there is varicocele associated pain also, that is an indication for varicocele repair. Is there an indication in azoospermia? Yes. In non-obstructive azoospermia, there is evidence to say that you can try for varicocele repair. In androgen deficiency, where the testosterone level, low testosterone level could lead to erectile dysfunctions, upgrade of sperm quality before ART, and elevated sperm DNA fragmentation and oxidative stress. All this could be reasons for varicocele repair. What are the techniques of varicocele repair? Microsurgical subinguinal varicostomy is there. Inguinal varicostomy could be there. Microsurgical versus loop magnification is there. Laparoscopic varicostomy is there. Percutaneous varicocele embolization is there. So it is the what about the outcome of treatment? Treatment of palpable varicocele in men with at least one abnormal sperm parameter resulted in 15% improvement in sperm count and 15% improvement in sperm motility compared with the control group. Significant benefit of varicostomy even extend to men with non-obstructive azoospermia and varicoceles. In one meta-analysis of azoospermic patients with varicocele, Esteves found that varicostomy lead to return of sperm on ejaculate in 43.9% of patients with 13.6% of natural pregnancy rate. In addition, they found that correction of varicostomy in this group was associated with increased sperm retrieval rates. So, even in non-obstructive azoospermia, varicostomy has got a role. The spontaneous pregnancy rate was achieved in 32.9% of patients who underwent varicostomy, whereas only 13.9% in the observation group achieved spontaneous pregnancy rate. Patients who underwent varicostomy were 2.9% times more likely to achieve spontaneous pregnancy. So, treatment of adolescent young men with testicular hypertrophy result in a catch-up growth in majority of patients. As with adult population, adolescents with abnormal semen parameters and varicocele experience significant improvement with treatment. This has to be. So, when a young adolescent comes to you with pain, this varicocele has to be considered and has to be serially followed up. So, pain resolution after microsurgical repair ranges from 53 to 93% for complete resolution. Patients experiencing dull aching or dragging pain were more likely to experience pain resolution with varicocele treatment. Varicocele results in significant improvement in testosterone level with low preoperative testosterone level. On average, varicostomy results in a mean increase in testosterone level. Hypogonadal men with low-grade unilateral varicocele are not thought to receive significant benefit from varicocele treatment. So, conclusion, most evidence support that treatment of clinically palpable varicocele in the context of male factor infertility. there is a good evidence for the treatment in symptomatic varicocele as well as in adolescents with testicular growth retardation and in abnormal semen parameters. Although most techniques have similar results in terms of outcome, each has its own advantages and disadvantages, and it is up to the provider and the patient to decide what will work best for them. So never be under the impression that varicocele doesn't help. It has its own role. It has got a role in and every steps of spermatogenesis, and even in adolescence and even in azoospermia, it has got a role.
Thank you so much, doctor. We kindly request you to please stay back onto the stage, please.